Thank you, Dr. Ahmed, for the introduction. Thank you, dear organizers, for inviting me to the very insightful conference today. I would like to extend my thanks and greetings to the moderators, the speakers, and the audience as well. Thank you very much. So I would like to start with some related definitions related to this very important topic related to the pediatrics population, which is neonatal blood exchange transfusion. So in this presentation, I'll talk about the definitions, indications, how to do the procedure, and I will end up later on with some of the complications related. So the neonates or newborns, according to the WHO, a neonate is defined as a baby who's 4 weeks old or younger. As you can see, the definition depends on the time after delivery. It doesn't mention anything more about the baby's state of illness, nor the disability, nor how long the baby was intrauterine, whether it was term, preterm, or post-term as well. This period of time is when the changes are very rapid. Many critical events happen in this period of time. For example, feeding patterns are established, bonding with the parents take place in this period of time, and the risk of infections that may become are more serious and higher in this period of time. Many birth congenital defects as well are first noted in this period of time. The preterm is defined as babies who are born alive before 37 weeks of gestation are completed. There are subcategories as well according to the WHO. Preterm birth is either subcategorized as extremely preterm, which are less than 28 weeks old, very preterm 28 to 32 weeks, and moderate 32 to 37 weeks old. In terms of the birth weight, so the normal birth weight is 2.5 to 4.5 kilograms. Low birth weight is defined as lower than 2.5 kilogram, and very low birth weight less than 1.5 kilogram. For the second part, which is exchange transfusion, it's defined as removing allicouts of patient's blood and replacing it with donor's blood repeatedly until blood volume is almost entirely replaced or exchanged. It's performed in order to remove abnormal blood components and circulating toxins while maintaining the adequate circulating blood volume. So it's vital to mention that the incidence of exchange transfusion is decreasing nowadays as a secondary to the prevention and improved prenatal management as well. The hyperbilirubinemia yet is very important, and exchange transfusion nowadays is the only modality of treatment after phototherapy fails. That's why it's important to learn and provide it as a blood bank service. Now, types of neonatal exchange depends on the blood volumes. These volumes are calculated using an estimate of neonate circulating blood volume, in which the term infants are 80 ml per kilogram and preterm infants have 100 ml per kilogram. The first type is partial exchange transfusion, on which it's used for polycythemia, for example, using normal saline, where desired hematocrit post-exchange is 50%. The second part, or the second type, is single volume exchange transfusion, which replaces around 60% of blood volume, and it's used for non-hemolytic diseases. The third is the double volume exchange transfusion, which is most commonly used for removal of bilirubin, and it replaces around 85% of the blood volume. As you can see, even the double volume exchange, it doesn't exchange 100% of the blood volume due to mix-up and contamination during the procedure between the donor's blood and the patient's blood. Now the indications, just like I said before, the most common is for exchange transfusion is hyperbilirubinemia, which is caused by hemolytic diseases of the fetus and newborn. The physiology in simple words is you're having a high bilirubin crossing the blood-brain barrier, which concentrates in the basal ganglia and cerebellum and would cause an irreversible damage known as kernicterus. Now, infants are susceptible to hyperbilirubinemia because of their immature liver conjugates the bilirubin poorly, and because their incompletely developed blood-brain barrier, it would allow bilirubin to transit. The phototherapy would convert the unconjugated bilirubin into water-soluble isomer, aiding into excretion, and just like I said before, this is the treatment of choice. Exchange transfusion is usually done for those patients who failed the phototherapy, and it needs to be performed before the development of kernicterus. In full-term infants, kernicterus rarely happens with bilirubin levels less than 25 milligram per deciliter. However, in sick, very low birth weight infants, kernicterus can occur at bilirubin of as low as 8 to 12 milligrams per deciliter. Usually a double volume exchange removes, just like I said before, 85% of the circulating cells and approximately 50% of total bilirubin. Just keep in mind that after the first exchange transfusion, bilirubin may re-equilibrate between the extravascular tissue and the plasma, which may necessitate another exchange afterwards. Now, other than hyperbilirubinemia, there are many indications, like polycythemia, congenital leukemias, thrombocytosis, but a person might wonder, like these indications, were they only enlisted in textbooks or were really reported? And the answer is yes, actually. In the 70s, there's digoxin, for example, a report of digoxin elimination after intoxication that was treated by the exchange transfusion. You have a report of paracetamol poisoning was ingested by a mother 16 hours pre-delivery that was treated by ET, and vancomycin as well, overdose by by a patient that was treated as well with the exchange transfusion. This is a report of lead poisoning by a neonate that resulted from the mother having long history of pica and eating glazed pottery, which showed rapid decrease in the neonate's lead levels after exchange transfusion as well. This one is a report about an exchange done post-transfusion, acquired malarial infection in a newborn, which was followed by introduction of quinine. Now, liver diseases, there's a case that was reported in 2013 about hemochromatosis by a neonate that was successfully managed by ET, and alloimmune liver disease that showed great results as well post-ET. Hypertriglyceridemia as well. But a person might ask, is it always green on this side of the field? For example, neonatal sepsis. Here's an RCT about the use of double volume exchange. In severe sepsis that showed a result of 21% reduction in mortality, which might sound interesting actually, but this one is a meta-analysis published in 2020 about the mortality in neonatal sepsis, with a conclusion that says, literally, the use of exchange transfusion in neonatal sepsis is not directly recommended due to low certainty of evidence, inadequate power, and moderate high risk of bias and heterogeneity. Now, that we know about the indications, the next logical question would be, how do I do neonatal exchange? To answer this question, actually two parts. You have a blood bank part and a neonatology part. Both are technical, but before getting into the details, just keep in mind a few points. First is that the final decision of ET is taken by a consultant neonatologist who's in service to decide on the ET based on the trend of serum, bilirubin levels, the response to the treatment, and if there was any history of intrauterine transfusion, for example, by a referring hospital. Now, other than the blood volume, the hematocrit, which are very important as well, the history of the neonate, special requests as well, and the urgency. The urgency of the exchange transfusion is very critical as well. Now, the component choice, which is very important for the blood bankers, typically it's RBCs resuspended in ABO compatible thawed fresh frozen plasma. Mostly it's O negative RBCs in AB plasma, but keep in mind that the maternal antibodies, if they are present, should be taken into consideration, because you don't want to use an O negative RBC for a patient who's having anti-small c or anti-small e. The final product should have a known hematocrit of 50 to 60%, leukodepleted as fresh as possible, which is less than 5 to 10 days. Some references say 14 days, less than 14 days, irradiated and used within 24 hours of irradiation. Now, in terms of irradiation, I want to expand a little bit more. Looking now, the irradiation for exchange transfusion is still debatable, actually. There are many international standards that recommend to start with irradiation. For example, locally or AABB on to irradiate for intrauterine transfusion, yes, but to irradiate for exchange transfusion only after IUT. In Europe, there's a division, and the practice is kind of institutional as well, as there are many international countries as well, and some institutions divide the patient according to their weight. Like, for example, the very low birth weight they recommend to irradiate for exchange transfusion. Primarily, some of them don't. Now, how do I reconstitute? This is mainly for the fellow lab scientists in the blood bank. It is kind of straightforward procedure and very easy once you have the basic elements. All you need is a weighing scale, and I'm sure that all of blood banks have a weighing scale. And you only need your high school base math, nothing else. So what you really do is you receive a blood bag, and usually the volume is indicated on this blood bag. Yeah? But what you end up with is, during the process, you would centrifuge it and take the additive solution and rest of plasma out. This means that you will end up with another volume. And the only way to know the volume inside this bag is by weighing the bag on the scale. That's why you need to convert the weight into volume by dividing by 1.06, which is the specific gravity of blood. And then you would subtract the weight of the empty bag, yeah? And using this formula, which is plasma to add formula, you will calculate how much plasma in volume, in ml, you want to add to the mother bag, You want to add to the mother bag. And then, when you calculate the volume, you would add them together, multiply by the specific gravity again, and you would add the weight of the empty plastic bag. The sum of all weights is the number you want to see on your scale while doing the process. It's the sum at the end of it. So please, I urge my lab colleagues, don't go with the back of envelope calculation on which you say, well, plasma is 55% of the blood. I want to give third of this, 23rd of that, bag it, tag it, and transfuse it. No, please. This is the formula. It's easy, straightforward, and I would like them to use it for better accuracy. Now, from the neonatology side, it's kind of straightforward as well. You need the critical personnel to be identified. 2 providers are required for the procedure, regardless of the method. They can rotate, but must be always around the time of the procedure. They order the blood, they calculate the volumes again, and determine the most suitable technique. A sterile bubble must be made during the procedure, and all steps must be documented, especially the pertinent times. Labs must be taken during and after the procedure, and prior to it as well. And you should keep in mind that blood sugar levels should be monitored as well. The vascular access, usual umbilicus vein, usually the umbilical venous catheter is used for the exchange transfusion, whether in term or preterm patients. And just like I said before, we have the 2 techniques, which is the isovolumetric exchange transfusion or the manual push and pull technique.
4 minutes, please.
Okay, thank you. The isovolumetric technique, you use 2 catheters, one inserted in the umbilical vein and one in the umbilical artery. They allow a simultaneous withdrawal and infusion of the blood. The manual pull and push technique uses a single vascular access with a 3-way stopcock attached to the unit of the blood, the patient, and a discard container. Usually, the recommendation is to attach a blood warmer as well. Now, important notes is to mention that with both techniques, the absolute maximum volume of each withdrawal and infusion depends on the infant's body weight, hemodynamic status, usually no more than 5 ml per kg of body weight, or 5% of infant's blood volume is removed and replaced during a 3 to 5 minute cycle. The exchange transfusion should not be performed rapidly because of sudden hemodynamic changes that would affect their cerebral blood flow and shift the intracranial pressure, contributing to intraventricular hemorrhage. A total double volume exchange transfusion typically takes 90 to 120 minutes. Now, the complications, which is the final part of my talk, they are either blood-related or procedure-related. For example, metabolic, they include hypocalcemia due to citrate present in the blood bag, probably hypo or hyperglycemia due to additive solution dilution, or hyperkalemia, for example, due to free potassium as a storage lesion or radiation. And by every complication, it's recommended to have a plan while doing the procedure. For example, the metabolic, you might have some infusions available nearby. For the cardiorespiratory, you might need intubation kit, or like for the cardiopulmonary complications, you might need a defibrillator or cardioversion as well. Hematologic complications are mostly dilutional, like thrombocytopenia, coagulopathy, neutropenia as well. And the list goes on. I hereby end my talk. Thank you very much for your listening. Thank you.